All right, we're gonna roll towards you on the number 3. 1, 2, 3.
I'm Dr. Walpert. We're going to be taking care of you today. I know there are a lot of people around you and it's scary, but we work as a big team.
I thought it might have been a little bit heat related, but his tachycardia never came down and stayed sustained.
I suggest we transport him, get some fluids on him hydrated.
What's up, bud?
I'm just dizzy.
Okay.
I don't know why.
All right, you feel like you're going to pass out?
Yeah, I just feel real weak.
Real weak?
Yeah.
Okay, let me get a pulse real quick on you.
If I'm not suspecting trauma, I'm simply going to go to a head tilt chin lift. When dealing with emergency care of the injured athlete, one of the most important parts is the athlete trauma survey. In order to appropriately treat the athlete, we must first recognize the problem. Timeliness is critical. You know, in a situation like this where you have a hockey player who has an arterial bleed from a skate laceration, timing can make a difference in life and death. So we must have a quick and very concise and orderly evaluation. And we all know in athletics emergencies happen. Now, fortunately for us, they don't happen with great frequency. When they do happen, you know, we must make quick decisions. We've got to be skilled in providing emergency care. Now, typically in an emergency situation, in most cases, the first responder is going to be the certified athlete trainer and or the emergency medical technician. Now, based upon our initial assessment, the first responder, whether it be the athlete trainer or the EMT, we have to make some decisions. Basically 4 things. Number 1, what's the extent and seriousness of the injury we see? Based upon that, what are our treatment options? Next, how are we going to package them? If it's a cervical spine injury, head injury, are we going to do full body mobilization with the spine board? If it's extremity injury, are we going to use a rapid form mobilizer? How are we going to effectively package them to safely get them to definitive care? And then last, transportation to a definitive care facility. Now, emergency medical technicians are different in many ways from athletic trainers in the way they're dispatched to an injury. Many times in an athletic setting, the athletic trainer is actually there and witnesses the mechanism of injury and makes a quick and rapid response. Our emergency medical technicians are usually dispatched by control. When they get there and arrive, the injury has already occurred, and many times emergency assistance has already been administered by an athletic trainer. EMTs may be unfamiliar with the mechanism of injury. They may not be familiar with the medical history of the patient, where many times athletic trainers are. Another primary difference between emergency medicine and athletic training is typically in an athletic setting, you're going to have an isolated injury, a knee, a head, a neck. Where in emergency medicine, you may have multi-trauma or multiple triage involving different patients. Because of this, emergency medical technicians for years have used an organized process to quickly obtain information vital to the patient's care. It's known as a primary secondary survey. Basically what they want to do is assess the level of consciousness, ABC, airway, breathing, circulation, provide immediate basic life support measures, and quickly make a decision regarding transportation. Norman McSwain is a trauma physician who worked for many years at the Baltimore Shock Trauma Hospital, and he coined a term called the golden hour. And it's based on the concept that definitive care cannot be provided in the field for the trauma patient. It's got to be done at a medical facility, and time is of essence. What Norman found out overall is after that first hour, the patient's chance of survival decreased dramatically. And although an hour or 60 minutes sounds like a long time, in reality it's not. Let's take a scenario where we have an athletic emergency on the field. We evaluate the athlete, we determine the extent of the seriousness of injury, we initiate 911. Let's say that situation took 5 minutes. Let's say we have a 15-minute response time from the paramedics to the scene. Now we're at 20 minutes. The paramedics arrive at the scene, they evaluate the patient. There's 10 more minutes there before they start transport. Now we're at 30 minutes. A 15-minute response time from the emergency setting to the hospital. Now we're at 45 minutes before they even arrive in the door of the hospital. Now, unless we're in a level 1 trauma center, there's not physicians available at that time. They may need to call the appropriate physician specialty. It could be in half an hour response time. So you see very quickly, an hour seems like a lot of time, but sometimes in an emergency situation, you know, it takes longer than we anticipate to get there. So anything we can do to speed up that process. For example, if we have a cervical spine injury, if we can package the athlete prior to the arrival of EMS, when they arrive, we can simply give them a quick update, load them on the unit, and transport them to the hospital, and we've saved several minutes of scene time. For example, again, if we have a cardiac arrest, by simply transmitting the ECG to the hospital, letting the cath lab know, the cath lab's open when the patient arrives, and we can facilitate moving up from the emergency room to the surgical procedure. Paramedics coin a term called load and go or stay and play, determining what we're going to do in the field once we determine the extent and seriousness of injury. What is a load and go patient? This is a critical patient, basically dealing with problems in respiratory, circulation, and a decreased level of consciousness. Now, compared to the emergency medical technicians, athletic trainers are a little bit different. They're generally familiar with the medical history of the athlete. Many times they do witness the mechanism of injury. And again, as opposed to the multi-trauma things which emergency medical technicians typically see, many of the things that they see involve one organ system or one anatomical area. Therefore, it's very easy to isolate the injury rapidly, and we can address it accordingly. And we can do a bridged or modified format with our evaluation. It's also important to understand that athletic event coverage may differ. For example, we may be in a game situation where we have paramedics on the sideline, and we have physicians and various specialties on the sideline. Or we could be in a practice setting where we may have one certified athletic trainer and a limited amount of help. So we've got to know how to utilize our manpower when we have them available. It's also important that we work together as a team. We may have different people from different settings. For example, you may have physicians from various specialties. Again, you may have paramedics, you may have certified athletic trainers, you may have athletic training students. We all have to work together as a team when an emergency situation arises. Let's take a case study and talk about emergency trauma survey. You're a college basketball athletic trainer. You're on the bench during the game. You're with your team physician. Your point guard intercepts a pass in midcourt, breaks for the basket. Just as he's about to do an uncontested layup, he's fouled from behind, and he's launched headfirst into the basketball standard. He falls to the ground, laying supine, motionless, appears to be unconscious. You and your team physician witness the mechanism of injury. It has the potential for a head and cervical spine as he contacted his head on the basketball standard. As you approach him on the floor, he's lying supine, motionless, moaning, his eyes are closed. As the athletic trainer, you provide C-spine stabilization and evaluate the airway. Your team physician checks his breathing and his circulation. The athlete's found to be breathing. He has equal radial and carotid pulses, and he is responsive to pain with a sternal rub. After approximately 30 seconds, the athlete opens his eyes and responds to voice. He says, "What happened?" As you question him, he's not exactly sure of his mechanism of injury, but he's oriented to the surroundings, person, place, and thing. His initial complaints to you are of a headache, of dizziness. He denies any nausea. Upon questioning, he denies any neck pain, and he has no other complaints. You do a quick neurovascular screening on the court with your team physician. The athlete asks, "Can I sit up?" You help him to a sitting position. After a brief observation, you're able to assist him from the court and take him back to the arena athletic training room for further evaluation in a quiet environment. Now let's take a second case study. You're a high school athletic trainer at football practice. During a live scrimmage, your fullback takes the ball and breaks upfield. Two linebackers hit him from intersecting directions, one high and one low. As the players unpile, several hurriedly call for the athletic trainer. As you approach the athlete, you observe him writhing in pain, going, "My leg, my leg." You observe an open tib-fib fracture. The athletic trainer, you dispatch one coach to go to the field house. Coach, go activate EMS. Call 911, tell them we have an athlete with an open tib-fib fracture. To the second coach, you dispatch him to open the gate to the football field and direct the ambulance in. Again, you're the only healthcare provider, so you have to utilize your resources. You have a student manager. "Joe, I want you to go to the shed and get the emergency equipment where we showed you it is." Using universal precautions, you place Sterigauls over the bleeding wound and apply direct pressure. You remove the sock and shoe so you can evaluate neurovascular status. You find that the athlete's distal pulses are intact, motor and sensation is intact. The ambulance arrives. You provide the history to the emergency medical technicians. You've assessed their vital signs and provide this information as well. With the assistance of the paramedics, you apply compression dressing, place a mobilizer on the athlete's leg. Again, you reassess neurovascular, and the athlete still remains neurovascularly intact. The athlete is transported. The coach accompanies to the hospital with the athlete. You get on the phone and contact the parents and advise them what's going on. You also contact your team orthopedic surgeon. As practice is still going on, you remain at practice to provide coverage. What we want to cover right now is what we call the athletic trauma survey. It consists of 3 parts: the scene survey, the primary survey, and the secondary survey. Each has distinct things we want to try to accomplish. My scene survey is simply as I'm approaching the athlete, whether we're on the mat, the football field, the basketball court, as I identify a possible injury and I'm coming out, what's my intake of this? What do I see? As I come out here, the first thing I want to see, is the scene safe? Is the scene controlled? For example, do we have a crowd dispersing around that we might have to push out to give us some space to do our job? Is the scene safe? Is the scene under control? The next thing is I approach the scene, do I see any blood or bodily fluids? I want to think about bloodborne pathogen protection and putting gloves on. The next thing is when we saw the mechanism of injury, is there a trauma mechanism where we need to think about a cervical spine injury? If so, I want to go ahead and maintain C-spine. Then I want to look about the number of victims we have. Do I need additional help? So step by step, again, the scene survey, really quick, should take about 10 to 50 seconds as we're approaching here. The next thing we want to move into is the primary survey. And the focus of my primary survey is LOC, ABC, level of consciousness, airway, breathing, circulation. As I approach the athlete, what's my general impression here? What do I see? If he or she is conscious, I want to ask him what their chief complaint is. If he's unconscious, I want to see, do I see any apparent life threats? And then step by step in a very orderly sequence I want to go through. The first thing I want to do is assess level of consciousness. And what I'm going to use is the AVPU approach, A, V, P, U. Is the athlete alert? John, can you hear me? Does he respond in an intelligible manner? If he is, he's A, he's alert. Okay. Does he respond to me if I do verbal stimulation? He may not be conscious or talking in normal conversation, but if I say, John, squeeze his shoulder, you okay? And he turns his head toward me or moans or shows any sign of communication, he responds to verbal stimuli. If he doesn't respond to verbal stimuli, I'm going to P. A, V, P. I want to do a painful stimulus. A simple one is a sternum rub. I'm going to take my knuckles and I'm going to rake across his sternum. Now, I may have an athlete in protective gear, for example, football pads or hockey pads, lacrosse, where I can access the sternum. A couple of the pots I can use for painful stimulus, I can take their hand and simply squeeze the web space. Or another painful stimulus, if I have C-spine and I have my hands right here and I have my fingers on his mandible, that's also another painful stimulus. If he does not respond to pain, he's unresponsive. So again, I want to think about AVPU, alert, responds to verbal, responds to pain, unresponsiveness. And I want to assess at this point right now, and as I go through my evaluation, I want to continue to assess on a serial basis to see if his level of consciousness changes. Next, I want to go to airway. I want to see, is his airway open? Is his airway patent? Now, if I'm not suspecting trauma, I'm simply going to go to a head tilt, chin lift. The most common cause of airway obstruction is the tongue collapsing on the back of the throat. If I have an unconscious athlete, tongue is a muscle, it simply relaxes and goes back. By going with the head tilt chin lift, I can very easily open this up. And I can maintain it with an oropharyngeal airway. If I'm suspecting trauma, I want to go to a modified jaw thrust. So I want to make sure his airway is open, make sure his airway patent. I want to look for any airway obstructions. For example, if he has a mouthpiece. If he took a blow to the face, maybe there's blood, vomitus, teeth fragments in there that I may need to remove. May need to think about using suction to clear the airway as well. Once his airway is open, I want to go and assess breathing. So I want to lean over the athlete and I want to look, listen, and feel. I want to look for chest rise. I want to listen for the breath sounds. I want to feel cheek puffs on my cheek. So look, listen, and feel. Now at this point, a couple critical factors. ABC, if I identify any deficiencies, I want to correct as I go. For example, if they have an airway issue, before I go to breathing, I want to correct an airway. If they have a breathing issue, I want to correct that before I go to circulation. So I want to correct as I go step by step. At this point as well, I'm not worried about numbers. I'm trying to make a quick assessment. Ideally, I want to do my primary survey in less than 1 minute. You know, are they breathing? Yes or no? What's the rate and the character of it? Is it fast? Is it slow? Is it deep? Is it shallow? Is there symmetrical chest movement? Are they experiencing pain there? Does it appear to be labored? So I'm just trying to get a quick assessment of rate, quality, and character of respiration. Next, I'm going to go to circulation. And what I want to do on circulation is I want to check the radial pulse and the carotid pulse at the same time. And the reason I want to do this, it not only gives me an idea of their heart rate, it also gives me an idea of their blood pressure. If he has a carotid pulse and a radial pulse, I know that his systolic blood pressure is at least 80. If he has a carotid pulse and he doesn't have a radial pulse, I know systolic pressure is below 80 and he's already in late shock, so we need to address shock at that point. Now, that tells me about primary circulation. I also want to think about some secondary circulation things as well. One is capillary refill. Simply take their hand and I want to squeeze his thumb and look at the nail bed. As I squeeze, it should blanch out. When I release, normal color should return in less than 2 seconds. Squeeze, 1001, 1002. That's normal capillary refill. I also want to check for skin color, skin temperature, using the back of my hand. Do I note anything? For example, if I have an athlete in shock, he may appear pale. When I feel his skin, it may feel cool. He may feel moist, he's diaphoretic. Then I can couple that with his primary circulation. He has a carotid pulse, no radial pulse. I'm thinking about shock. So I'm trying to put this step by step together and do a differential diagnosis. Also want to look for and control any major bleeding that I see at this point as well. So that's basically my primary survey. Again, less than a minute, levels consciousness with APU, alert, response to verbal, response to pain, unresponsive, airway, breathing, circulation. Now once I've done this, I need to make a quick assessment of the athlete. Is he what we call a load and go, which is a true emergency, or stay and play? And what defines load and go? If I have any deficiencies in level of consciousness, airway, breathing, circulation. Scene survey, primary survey. Now I'm going to my secondary survey. This is a more detailed, systematic head-to-toe assessment. So I'm going to start with the head. The first thing I want to do is take a pen light and I want to evaluate his eyes. I'm going to open up and I'm going to check and see, are his pupils equal in size? They respond to light. Pupils are dilated. When I shine a light in, they constrict. So his pupils are equal and responsive to light. Next, what I'm doing is observing with my eyes. I'm palpating with my hands for any deficiencies or deformities I see. Do I see any blood? Do I see any clear liquid coming from the ears, the nose, which might be cerebrospinal fluid? Do I see any discoloration or ecchymosis? For example, raccoon eyes or battle sign with bruising in the mastoid process may be indicative of a basal skull fracture. As I observe, I'm also going to palpate the major bony structures of the face and then go into the back of the head. So assessing the head, then moving to the neck. The first thing on the neck, I want to inspect the front of the neck. I want to see if its trachea is in midline. And I want to look for JVD or jugular vein distension. If I see tracheal deviation or JVD, the two things I want to think about are major chest trauma, cardiac tamponade, or tension pneumothorax. Next, I want to go to the back of the neck and I gently want to palpate along the spinal column. Do I appreciate any deformity or step off? Any crepitus? Do I listen to any pain? Next, I want to go to the musculature of the neck, the paraspinals. So front of the neck, back of the neck. Moving down the body, going to the chest now. I want to inspect the chest. I can cut or I can pull the shirt off. Do I see any asymmetries? For example, somebody said chest trauma, they may have a flail chest where they have two segments broken in two or more places, and I have that paradoxical movement when they're doing respirations. Assess the chest. Next, I want to palpate the chest. I want to take a hand on their sternum and press straight down. Now I want to take my hands on either side of the chest and pushing on the rib cage. Again, do I elicit any pain? Do I feel any crepitus? Do I feel any deformity? Next, I want to take the stethoscope. I want to auscultate the chest. What I want to do is do the 4th and 5th intercostal midexillary line. My landmark is my nipple line, going straight down in the axilla. Listening for breath sounds. Coming to the other side. Are the breath sounds equal and bilateral? Do I have normal chest rise and fall? Do I hear normal breath sounds, or do I hear some abnormal things like wheezes, which may be indicative of asthma, stridor, which you might see with anaphylactic shock, crackles or rail or rhonchi? Next, I want to auscultate heart tones. Stethoscope just to the left of the sternum. And listen briefly to the heart rate. What's the rate? Is it fast? Is it slow? Is it regular? Is it irregular? So again, moving a systematic step down the body, head, neck, chest, abdomen. What I want to do is draw an imaginary line between the umbilicus, and I want to divide the abdomen into 4 quadrants. Upper right, upper left, lower right, lower left. I gently want to palpate in, pushing, releasing. Do I feel any abdominal rigidity muscular-wise? Do I appreciate any pain? Do I have pain when I push in? Do I have a rebound sign when I release? And step by step, upper right, lower right, upper left, lower left. Moving down to the pelvis. I want to take my hands directly on the ASIS, push straight down. Again, do I eliminate or elicit crepitus? Do I cause any pain? Now on their iliac crest, pushing straight in. I want to avoid any rocking. Straight down ASIS, straight press in on the iliac crest. If appropriate, we may need to inspect the genitalia based on the mechanism of injury. If not, I'm going to extend my assessment. I'm going to start with the lower extremities now, moving down. Basically, I want to start with the upper thigh. I want to palpate down. Again, looking with my eyes, do I see any deformity? Ecchymosis, discoloration, and obvious deformities such as a knee dislocation or ankle dislocation. Moving on down the body. Now, one thing, in order to assess, we have to expose. So it may be appropriate to take their sock and shoe off so we can assess neurovascular status. If we have a possible ankle injury or a foot injury, it may be more feasible to cut the shoe off. You can simply cut the laces here, spread the shoe. If you have a high top, you can take your scissors and you can cut on either side and open the shoe up more. Remove the shoe. Again, if we have a major lower extremity injury, it may be more appropriate to try, rather than trying to take the sock off, we can tin it, cut it here, and then cut up the sock to facilitate removal. Okay, once we're at the lower extremity, we want to think about 4 things. P, M, S, C. Pulse, motor, sensation, and capillary refill. The first thing we want to think about is pulse. On my foot, I have 2 distal pulses. One is the dorsalis pedis. It's located right between the 1st and 2nd met in the west space right here. Once I find it, ideally, if I can take a Sharpie or a pen and mark it, that facilitates somebody else in the evaluation. If we're trying to do serial neurological status, I may be doing vital signs, somebody else may come in, they can immediately find where this pulse is. Dorsalis pedis. Next, I want to think about the posterior tib. I want to palpate their medial malleolus, go straight back and down in the soft spot right here, and there's the posterior tib. So distal pulses. Motor. If they're conscious, I'm going to ask them, can you wiggle the toes? Very good. We have intact motor. P, M, S, sensation. Can you feel that? Yes or no? Now, obviously, with an unconscious athlete, we cannot get motor, we cannot get sensation, but we can still get pulse and capillary refill. So P, M, S, C. Capillary refill, just like with the hand, I want to squeeze their toenail, blanch, 1001, 1002. Now, if I have a female athlete, Maybe somebody with nail polish, you can simply do the base of their foot or fingernail polish. We can do web space the same way and assist for capillary refill there. So pulse, motor, sensation, capillary refill. I'm going to go to the other extremity, do the exact same thing again. Once I have that, I'm going to come back to the upper extremity. Again, the concept of head to toe, we want to make sure we cover every body part. So upper extremity, palpate the shoulder. Any deformity, any crepitus, any elicitation of pain. Moving down the body. Now again, pulse, motor, sensation, cap refill. Radial pulse. Nice, strong radial pulse. Motor. John, wiggle your fingers. Make a fist. Very good. Sensation. Do you feel that? Very good. Cap refill. Then repeating that on the other side. So PMSC, one part of the body we haven't got yet, and it's one of the most commonly overlooked, is the back. Many times people in a supine athlete forget about that. We want to make sure we assess and sweep the back. So at some point in the process, and it may be in the log roll maneuver, whenever we can access, we do want to evaluate, sweep the back again, palpating, inspecting, any deformity, any elicitation of pain, elicitation of crepitus, and then roll them back over. So scene survey, primary survey, secondary survey. Now secondary survey consists of 3 separate parts. We just did the first part with the head to toe survey. Now I'm going to have one of my assistants come in, and ideally if we have more than one person here, we could actually do several things at one time. The second part of the secondary survey is vital signs. So we're gonna bring our trauma bag in here. There's 3 vital signs we always want to get at a minimum. In the secondary survey, now we're getting numbers. If you remember the primary, are they breathing? Yes or no? Fast or slow, shallow or deep? Now I want a hard respiration count. How many times are they breathing in a minute? In the primary survey, we're just checking to see if they had a radial carotid pulse. Was it fast? Was it slow? Was it strong? Was it weak? Now we want to get a hard number. At a minimum, I want to get 3 vital signs. And what Anisha is bringing out now is called a pulse oximeter. They make a smaller handheld one. This is a different model, but something you're simply going to slide onto the athlete's finger, and that'll give me a running record of his pulse and also his O2 saturation. Now, why is this important? If they have any airway breathing difficulty, I want to make sure if oxygen is indicated, we need to monitor the effectiveness of it. And we can only do this with O2 saturation. Normal O2 saturation should be 95 or above. So we're going to get a pulse, we're going to get a blood pressure, we're going to get a respiration. If we have any airway breathing difficulties where we're using oxygen, we want to make sure we have a pulse ox as well. Now, temperature may or may not be indicated based on the situation. If it's a trauma situation, many times temperature may not be indicated. But for example, if I have an exertional heat injury, I definitely want to get a temperature. If I'm concerned about a core temperature, the only way to go is a rectal temperature. So I want to think about secondary survey consists of head to toe survey, my vital signs where I'm getting numbers at. My last part is a sample history. And this is based upon whether the athlete is conscious or not. Now, if the athlete's conscious, ideally, I want to get that information for him. If the athlete's unconscious, I may have to get it from bystanders. It may be from my knowledge of his medical chart or for family members or friends. The sample history consists of 6 parts. S, signs and symptoms. Has he been having any signs or symptoms immediately before this activity? For example, he collapsed in mat drills. He may be a sickle cell trait athlete. Has he had any viral symptoms the last 24 hours? Maybe he had nausea or vomiting, diarrhea that we weren't aware of. So any signs or symptoms he may have. A is for allergies. Is he allergic to anything? Medications, foods, insects. Sample history, signs and symptoms, allergies. M is for medications. Is he on any medications which may have bearing on this? If we're going to transport him to the hospital, the physicians need to know about this. The paramedics need to know for any possible drug interactions. S, A, M, P. Past medical history. Does he have any pertinent past medical history that I need to be aware of? For example, diabetes, asthma, sickle cell trait, concussion history, anything that may have a bearing on the situation right now. L, last oral intake. When was the last time he had any food or drink particularly as bearing, for example, if he's immediately going to surgery. And the E, events preceding. Are there any things that happened here beforehand that may have a bearing on this case? So the athletic trauma survey is a very detailed assessment going step by step through the body. The first thing again is my scene survey, just about a 10 to 15 second intake as I approach the athlete. What's my quick impression? Then moving to my primary survey, LOC, airway, breathing, circulation. If there's impairment there, they're a load and go athlete. Then moving to my secondary, which is a more detailed assessment consisting of 3 parts. My detailed head to toe survey, my baseline vital signs, and my sample history. After we complete our secondary survey, we've gone through everything. If we've identified any areas, we may want to go back and do a more focused assessment there. For example, if they have a knee issue, we may want to go do a more focused assessment there. We want to manage the injuries, and we also want to think about serial assessment. We want to go back and reassess their level of consciousness, reassess their vital signs every 5 minutes. One thing to think about too, athletic injuries are very different from what many times we see in an emergency medical setting. You know, for example, if you're in a motor vehicle accident, you may have multi-trauma where you have a head injury, a chest injury, a pelvic injury. It's necessary to do the whole step-by-step head-to-toe survey. But many times in an athletic injury, it may be an obvious knee dislocation, and we can do a bridge format where we go strictly to the area and isolate that. So we want to know the whole format, but it's not always necessary to do the entire head-to-toe survey. We're going to base it upon the individual circumstances for that injury. The athletic trauma assessment, when we have an injured athlete, we need to have a systematic, orderly approach. It requires thinking very precisely under pressure. By having an organized sequence, it'll allow us to not make any mistakes or miss anything in this evaluation process. Again, the thing we want to think about in an emergency situation, time is critical. And we want to make sure we have a rapid but accurate assessment so we can determine effectively how to treat the injured athlete.